On today's episode of Make It Make Sense Cardiology, we're going to talk about myocardial bridging. And FYI, go ahead and get very familiar with your save button because all of the lessons for this week, you're going to want to keep them. These are big, and I have been preparing for such a time as this. Starting with this one, myocardial bridging. What is it? Myocardial bridging is a condition that is rarely discussed in nursing school, but is ever present in the real world. Now, with myocardial bridging, what happens is that the coronary arteries, those are the blood vessels that bring blood flow into the heart. The coronary arteries, instead of sitting on top of the heart and bringing blood flow in through the distal ends, that doesn't happen with myocardial bridging. Instead, what happens is those blood vessels, those coronary arteries, they're actually embedded into the muscle of the heart. So your patient will feel very genuinely like they're having a heart attack, literally with every heartbeat. Because what is happening? Because those arteries are embedded into the heart muscle, every single heartbeat, every single systolic phase, every single contraction of the heart is squeezing those vessels. What happens when you squeeze those arteries? It impairs blood flow. What happens when you impair blood flow to the heart? Ischemia happens. So you will have a patient who is presenting with the symptoms of an MI, that's a heart attack. You will have elevated cardiac enzymes, but when they get to the angiogram to try to find out where any blockages lie, you won't find any. It does not diminish their symptoms. It does not diminish their feelings, but it does validate the diagnosis of myocardial bridging, because you will then have an eye view of what the heart muscle is doing by way of angiogram. Ooh, let's open this up, dive in a little bit further. Myocardial bridging, once you have again discovered, or your cardiologist has discovered, that your patient has no blockages to account for their symptoms, and they see that the arteries are actually running through the heart muscle, how do you help this patient? Treatment options aren't as complicated as you think. Walk through it, all right? Don't just try to memorize steps. Walk through the process. What did I say from the beginning? The problem is that the muscle of the heart is actually squeezing the artery, and that impairs blood flow going through the artery. So what's the remedy? Tell the muscle, don't squeeze as hard. What medication tells the heart muscle, slow down on that force of contraction? Don't squeeze with such tightness. It's not a beta blocker. I know that is the first inclination, is to think a beta blocker, slow the heart rate down. We're not interested in the heart rate. We are interested in the force of the contraction. Those medicines that impact the force of contraction, those are your calcium channel blockers. But which ones, nursing students and new graduate nurses? Which calcium channel blockers tell the heart muscle directly, chill out on the force of contractility? Yeah, the non-DHP ones. These are your verapamils. These are your diltiazems. They decrease the force of contractility, ergo taking some of the pressure off of those coronary arteries. Now, you do have some patients who may not necessarily be the best candidate for these non-DHP calcium channel blockers. Let's say you got somebody who's already a touch bradycardic. You don't want to add any decrease in contractility to that. Or you may have somebody who already has a little bit of systolic dysfunction, like a low ejection fraction. Don't want to add any decrease in contractility force to that. So what are these patients left with? They're left with nitrates. What do nitrates do, student and new graduate nurses? Nitrates actually cause vasodilation. Remember that? Yeah. So if you've got a patient with myocardial bridging who is not a good candidate for a non-DHP calcium channel blocker, this is when you will see a nitrate involved in their medication regimen. Now, obviously, you can't have umbrella fixes for every single patient. Everything has to be tailored. So it's not to say that beta blockers would never come into the topic of conversation. They very well may be. You have to do what is best for your patient given their individual clinical context. But just understand the process. Myocardial bridging, big time squeeze on the arteries that bring blood flow into the heart, because the arteries are actually embedded into the cardiac muscle instead of sitting on top. Reduce the force of contractility with the myocardium, take some of the pressure off of those arteries. If you can't do that, help the arteries stay open a little bit longer. That's done by way of nitrates. Last case resort, you got a little bit of beta blocker action that you can use to swoop in and help save the day. It is important, here's your take home, it is important to make sure that your patients understand what is happening to them. And I know many times the provider will have these conversations with patients, but they may not be in the right headspace to absorb the information that we give to them at the time. So nurses, this is where we lean on you as providers. Once you understand what is going on in the patient's clinical context, you are able to take this medical jargon and translate it into the language that they can understand. When patients understand their conditions, anxieties get allayed or at least brought down some, and then we can work on a path to recovery. I told y'all were gonna like this today. Like, share, follow, repost, all that jazz. Thank you, as always, for your time. Get ready for the next class session. Until then, y'all are dismissed.